Assalamualaikum warahmatullahi wabarakatuh, and a warm welcome to everyone joining us today. Thank you for tuning in to the fifth series of our SHENA webinar held in conjunction with the World Day for Safety and Health at Work 2025. My name is Haji Mohammad Khairul Aminudin bin Haji Abu Bakar from the Enforcement Division, and I am pleased to be your presenter for this session. Today, I will be presenting on the topic Empowering Occupational Diseases Reporting for a Healthier Workplace. Our focus will be on how we can collectively strengthen the process of occupational disease reporting to improve workplace health outcomes. Let's start by briefly going through today's presentation outline. First, we'll cover the introduction to occupational health. This will include definitions and the background of occupational health, providing a foundational understanding. Next, we'll discuss occupational health hazards and their examples. Moving on, we'll look at examples of contraventions on occupational health requirements. This section will highlight common non-compliance issues and how they can impact workplace safety. Following that, we'll present global and occupational disease statistics to highlight the global burden and trends of occupational diseases. Our fifth section is about empowering occupational disease reporting, focusing on why it's important and how to encourage better reporting practices. Next, we'll touch on relevant publications related to occupational health that can be valuable resources for everyone. We'll then discuss our inspection campaign. This includes the objectives, findings, challenges faced, and recommendations for improvement. And lastly, we will look at the Tripartite approach, which is a collaborative framework involving government, employers, and workers in managing occupational health issues. Before we proceed further, let's clarify some key definitions related to occupational health. Occupational health is a broad discipline. It is all about protecting, promoting, and maintaining the highest degree of physical, mental, and social well-being of workers across all occupations. Within this field, we have two main branches. Occupational medicine, this is the medical side. It focuses on preventing, diagnosing, and managing work-related injuries and diseases. Occupational physicians play a key role in medical surveillance, diagnosis of occupational diseases, and advising on fitness for work. Then we have occupational hygiene. It involves anticipating, recognizing, evaluating, and controlling health hazards in the working environment. Occupational hygienists assess exposures to hazards like chemicals, noise, dust, and ergonomic risks and work to eliminate or minimize them. These two branches interact directly with exposure and disease, as illustrated in the flow diagram. Occupational hygiene addresses the exposure side of the chain, the point at which workers come into contact with hazards. Occupational medicine comes into play when exposure results in a disease. And finally, we define occupational disease as any disease specified under Schedule 3 of the Workplace Safety and Health Act, Chapter 277. So, in summary, occupational hygiene and occupational medicine are two critical disciplines that work together under occupational health to prevent and manage work-related illnesses, ensuring both proactive and reactive approaches to worker well-being. Before we dive into the outcomes of our inspection campaign, let's first look at the current landscape. The reality is, workplace injuries are reported more effectively compared to occupational diseases, or ODs. This highlights a critical gap in our occupational health system. Unlike visible injuries, ODs often develop silently over time, making them harder to detect and easier to overlook. Yet, they carry long-term consequences for the worker and the workplace. Health clinics and medical practitioners play a vital role as the first gatekeepers. They are the first point of contact in identifying, diagnosing, and managing potential occupational diseases. Once a diagnosis is confirmed, it is not the end of the responsibility. Under Regulation 6 of the WSH Incident Reporting Regulations, both the registered medical practitioner, RMP, and the employer are legally required to report confirmed cases of occupational diseases to SHENA. This reporting process is essential, not just for regulatory compliance, but for early intervention, data-driven prevention strategies, and ultimately to ensure the well-being of our workforce. Next, occupational health hazards refer to the various risks in the workplace that can affect workers' health and well-being. These hazards are typically categorized into 5 main groups: chemical, physical, biological, ergonomic, and psychosocial hazards. First, let's talk about chemical hazards. These include exposure to harmful substances such as carbon monoxide gases, benzene liquid and vapors, silica dust, asbestos fibers, and organic fumes like pesticides. These chemicals can be inhaled, ingested, or absorbed through the skin, leading to serious health problems. Next are physical hazards. Physical hazards in the workplace include noise, vibration, extreme heat and cold, as well as ionizing radiation. These hazards can cause injuries or chronic health issues if not properly controlled. Moving on to biological hazards, these involve exposure to harmful biological agents such as Legionella bacteria, hepatitis B and C viruses, E. coli bacteria, and Aspergillus virus. Biological hazards are common in healthcare, food processing, and other environments where exposure to infectious agents is possible. Ergonomic hazards are another important area to consider. These hazards arise from poor workplace design or work practices. Examples include excessive force, awkward postures, repetitive movements, prolonged duration of tasks, and overall poor workplace design. Such hazards can lead to musculoskeletal disorders and other injuries. Finally, there are psychosocial hazards. These hazards stem from the social and organizational aspects of work. They include work pressure, stress, depression, fatigue, and poor support. Psychosocial hazards can significantly impact mental health and overall well-being. Understanding these 5 categories of hazards is crucial for effective risk assessment and prevention, ensuring the health and safety of all workers in the workplace. Here's a real example of an occupational health contravention involving dust exposure captured in a video. In the video on the left, a worker is seen using a blower to clean up accumulated dust, which in turn caused the dust to become airborne. This practice significantly increases inhalation risks for all workers on site. Several issues were identified. Firstly, there was no risk assessment conducted to manage dust exposure in contravention of the WSH risk management regulations. Secondly, the practice of dry sweeping with a broom and blower introduced dust into the air, violating WSH General Provision Regulation 39, which addresses toxic dust, fumes, or other contaminants. Thirdly, there was no air monitoring to ensure that exposure levels did not exceed the permissible exposure level, as required by WSH General Provision Regulation 40. Lastly, there was inadequate use of PPE, contravening WSHA Section 12 and 15 on the duties of employers and persons at work. This example demonstrates why proper risk assessment, air monitoring, and the use of appropriate PPE are essential to protect workers from hazardous dust exposure. Here's another example of an occupational health contravention, this time focusing on poor chemical management. As shown in the photos on the top left, there are several issues. Hazardous chemicals have been transferred into decanted, unlabeled containers. There are no proper warning labels on these containers. Safety data sheets for these chemicals are not readily available. The storage conditions are improper, with chemicals stored haphazardly and in unsuitable areas. There's also poor handling and usage practices observed on site. These practices contravene several sections of the WSH General Provisions Regulations, including Regulations 41 to 43, which address hazardous substances, warning labels, and safety data sheets. The bottom images show best practice examples, including proper housekeeping and clear warning labels, as well as an emergency wash station, highlighting what safe chemical management should look like. On the bottom right, we see how these chemical hazards can enter the body through inhalation, skin contact, or ingestion. These routes of entry can lead to serious health effects like cancer, dermatitis, asthma, allergic reactions, irritation, and burns. This example underscores the importance of proper labeling, storage, and safety measures when handling hazardous chemicals in the workplace. This slide highlights an example of an occupational health contravention related to noise exposure in the workplace. The top left image shows a risk assessment identifying noise as a hazard in abrasive grinding activities. In the center left image, a hygiene survey was conducted to check noise levels, and we can see that earplugs were properly worn. However, on the top center and right images, workers were observed working in a noisy environment without any hearing protection, which is a clear contravention of noise exposure control measures. On the bottom left, there is an OH information notice to raise awareness about noise hazards. The bottom center image shows that a machine enclosure was open, leading to an increased noise level in the work area. The bottom right image shows poor maintenance of earmuffs, which compromises their effectiveness in protecting workers' hearing. This example demonstrates that while some control measures were in place, such as risk assessment and hygiene surveys, there were significant gaps in consistently applying hearing protection measures, maintaining PPE, and controlling noise at its source. Such gaps highlights the importance of not only conducting risk assessments, but also ensuring effective and consistent implementation of noise control measures to protect workers' health and hearing. Now let's take a closer look at the global and national picture of occupational diseases, or ODs. According to joint studies by the World Health Organization and the International Labour Organization, there are an estimated 2.93 million work-related fatalities every year. Out of this, only 11% are due to injuries. The vast majority, 89%, are due to work-related diseases. This staggering figure underscores what we often refer to as a hidden epidemic, because these diseases are frequently underdiagnosed, underreported, or simply overlooked. If we shift our focus to Brunei Darussalam, the number of OD cases reported from 2017 to 2024 has remained extremely low, with just 4 confirmed cases reported so far in 2024. That is an incidence rate of 1.80 per 100,000 workers in 2024. In contrast, Singapore, which has a more mature reporting system, recorded 899 OD cases in 2024, with an incidence rate of 24.4 per 100,000 workers. While the numbers vary by country, the contrast clearly raises the question, are we underreporting ODs? This data should prompt us to reflect on our current practices and systems, especially in terms of awareness, diagnosis, and mandatory reporting. It also reinforces the need for stronger collaboration between medical practitioners, employers, workers, and regulators. It was suspected that the actual number of cases may be higher than reported, which is a challenge also observed in many other countries. Several contributing factors have been identified globally, including the long latency period of some occupational diseases, difficulty in establishing work-relatedness, and limited awareness or capacity among practitioners to diagnose and report. In response, an inspection campaign was launched to investigate and verify this issue, and more importantly, to identify any gaps in the reporting process by registered medical practitioners, a step that mirrors similar efforts in other countries facing the same challenge. Considering the underreporting concerns and the lack of enforcement awareness among registered medical practitioners, the Occupational Health Unit under the Enforcement Division launched its first inspection campaign with a dual purpose: to increase awareness and to verify compliance with OD reporting requirements. This campaign adopted a hand-holding approach, meaning we aim to engage clinics constructively, guiding and supporting them rather than simply auditing them. The initiative was aligned under the campaign theme of reporting for a healthier workplace. The inspection campaign was conducted over a 6-month period from September 2024 to March 2025. Initially planned for a shorter time frame, the extension was necessary due to real-world challenges, such as difficulties in booking time with clinics who were attending to walk-in patients or who had doctors operating overseas. Now let's break down the campaign's focus. The main aim was to raise awareness among RMPs about their legal duty to report occupational diseases to SHENA within 10 days of diagnosis. The objectives were threefold: to verify whether private health clinics have a proper process in place for OD incident reporting, to identify gaps and challenges that hinder effective reporting, to determine the way forward in overcoming these obstacles. And finally, the expected outcome of this initiative is to help address underreporting concerns and to develop an evidence-based nationwide preventive strategy for managing occupational diseases in Brunei. This campaign marks a proactive step in strengthening our occupational health system through collaboration, data, and practical enforcement. To support our inspection campaign and improve understanding of occupational disease reporting requirements, SHENA developed and published several key materials targeted specifically at private health clinics and registered medical practitioners. First, we issued a formal note to industry, reference 2024/NTI/07, dated 20th August 2024. This served as an official notice to inform and engage private medical clinics about the inspection campaign and to remind them of their obligations under the Workplace Safety and Health Incident Reporting Regulations 2014. Next, we produced a poster titled Empowering Occupational Diseases Reporting, Reporting for a Healthier Workplace. This was designed to provide a quick visual summary of key facts, including statistics on work-related diseases, legal responsibilities of employers and RMPs, and clear steps on how to report suspected occupational diseases to SHENA. This poster was intended for prominent display in clinics and medical facilities. We also developed a more detailed OD reporting leaflet, which breaks down the types of occupational diseases listed under WSHA Schedule 3, provides examples of notifiable conditions, and explains both the legal implications for non-reporting and why reporting matters. It also includes a QR code for immediate access to SHENA's online incident reporting platform, making the process more efficient and user-friendly. Together, these three publications, the NTI, poster, and the leaflet, form the backbone of our education and awareness strategy for improving compliance and strengthening the national OD reporting culture. Let's move on to the key findings from our inspection campaign. An inspection campaign was successfully completed, targeting 30 private health clinics. This campaign accounted for 38% of the total inspections conducted by the Enforcement Division during the reporting period, focusing on improving occupational disease reporting in private clinics. This reflects our ongoing commitment to strengthening surveillance and reporting of occupational diseases in these facilities. Secondly, we engaged with a total of 48 registered medical practitioners as part of our outreach and capacity building efforts. These engagements allowed us to capture not only what systems were or were not in place, but also to understand the perspectives, knowledge, and challenges faced by the practitioners themselves when it comes to OD recognition and reporting. On the right, you will see a pie chart illustrating the proportion of clinics that have doctors with an occupational health background. Findings showed that 57% of the doctors do not have an occupational health background, indicating their primary focus is general practice or family care. Meanwhile, 43% reported having occupational health training. However, only a few clinics made referrals to the Ministry of Health for suspected occupational disease cases. The majority opted to treat the illness without initiating further investigation as an occupational disease case. Of course, all the doctors are medically licensed to practice. However, not all are specialists in diagnosing occupational health matters, that is, determining whether a disease is indeed a work-related or caused by other factors. Reaching a conclusion on an occupational disease diagnosis requires extensive clinical testing, examinations, assessments, and qualitative studies. Limited resources and facilities further constrain the doctor's ability to make such determination. This suggests that while there is some level of OH expertise in the private clinic sector, there remains significant room for improvement to ensure better diagnosis and reporting of occupational diseases. This slide highlights further insights from our inspections. 85% of the registered medical practitioners were engaged reported that they only sometimes or rarely encounter OD cases. 74% of the RMPs were unfamiliar or only somewhat familiar with OD reporting requirements under WSH Incident Reporting Regulations before our inspections. This can also be one of the reasons why reporting of occupational disease is very low, as the majority of the doctor is not aware of their responsibility to make the report on OD to SHENA and their limited capacity to make the diagnosis. However, following SHENA's Enforcement Division inspection, 88% of the RMPs reported that they now understand the OD reporting requirements. We assume the remaining percentage came from clinics where the doctor was not directly engaged during the inspection. On the right side, you can see the before and after comparisons. Before the inspection, only 26% of RMPs were very familiar with OD reporting requirements, while 41% were not familiar at all. After the inspection, The familiarity significantly improved, with 44% of RMPs now reported being very familiar and 44% being somewhat familiar. These findings highlight the importance of continuous engagement and capacity building efforts to ensure private clinics and RMPs are fully aware of their reporting obligations under the WDSH regulations. This section further explores some of the practical challenges observed during our inspections. During the inspections, potential occupational disease cases related to skin diseases, noise-induced hearing loss, and musculoskeletal disorders were identified. However, as mentioned earlier, the RMPs generally focus on treatment rather than investigating the root cause of these conditions. Furthermore, if the RMP did not specifically ask OD-related questions during patients' consultations, it became challenging to confirm whether the condition was truly work-related. Finally, once a potential OD case is identified, and if the clinic does not have the capacity to confirm it, the case is referred to the Occupational Health Division (OHD) at the Ministry of Health for further evaluation and confirmation. This highlights the importance of strengthening root cause investigation and comprehensive occupational history taking during clinical assessments. Now let's explore the key challenges shared by the doctors during our inspections, which reveal why occupational disease reporting and management can be practically complex and often hinder the effectiveness of these processes. First, under multifactorial issues, we observe a lack of continuity in care and no baseline data on workers' health, making it harder to track trends. For example, patients often change clinics, making it difficult for doctors to have a complete history of their specific health conditions. Some occupational diseases have a long latency period, meaning symptoms may take years to appear. For instance, exposure to asbestos can take anywhere from 10 to 40 years, or even longer to manifest, depending on the level of exposure and the individual's health status. Most occupational diseases progress slowly, which is why prevention and long-term health surveillance are crucial. Workers often seek treatment only, without further investigation into whether the disease is work-related, limiting early detection opportunities. Patient confidentiality concerns sometimes conflicted with the need to report OD cases. Some clinics also have contracts that discourage them from reporting to SHENA. Second, there are clear training and competency gaps. Many registered medical practitioners experience difficulty diagnosing ODs due to the lack of clear guidelines or diagnostic criteria. And in some cases, we see limited interest or focus on occupational health among RMPs. Third, challenges also shared with regards to process related for line of reporting. Accessing specialist input from both parties often requires additional time and follow-up, which can delay confirmation and reporting. Finally, there are also repercussions that contribute to underreporting. There is a fear of job loss among employees if they report an occupational disease. Private clinics worry about losing business from employers if they highlight these issues. There are also cost concerns around diagnosis and reporting. And finally, the lack of awareness of RMPs in regard to legal protection to report cases to SHENA. These challenges show us that improving OD reporting is not just about inspections. It requires coordinated action, from better training and clearer legal frameworks to supportive reporting processes and collaboration across ministries and stakeholders. Finally, based on our inspection findings, we would like to highlight several key recommendations provided by the RMPs to enhance the effectiveness of occupational disease reporting and management. These recommendations include, firstly, the development of clear guidelines for diagnosing ODs to ensure consistency and accuracy in case identification. Next, the need to raise awareness on the importance of OD reporting, targeting both RMPs and employers. Thirdly, the publication of Registered Designated Workplace Doctors (DWD) to provide better reference and guidance for the medical community. Fourth, strengthening competency among RMPs and health professionals so they are better equipped to identify and report ODs. Finally, establishing a clear referral process to the Occupational Health Division (OHD) under the Ministry of Health to help clinics manage cases that fall outside their capacity to confirm. Let's now discuss the tripartite approach, which is fundamental to managing occupational health effectively. This approach involves three primary stakeholders: the government and designated health professionals, including industrial hygienists and workplace doctors, who establish standards, provide guidance, and oversee compliance; the worker, who must be proactive in recognizing hazards, participating in health surveillance, and promptly reporting any occupational health concerns; and the designated workplace doctor, who is responsible for the accurate diagnosis of occupational diseases. Importantly, once an occupational disease has been diagnosed, the RMP is legally obligated to report this case to SHENA, ensuring that it is properly documented and addressed in line with regulatory requirements. To support this process, both RMPs and employers are required to use the Initial Incident Notification (IIN) online form, which is available on the SHENA website at www.shena.gov.bn. Submitting reports through this platform ensures timely and accurate documentation of occupational disease cases. On the right of the diagram, the role of government and health professionals in the recognition and evaluation of occupational health issues is depicted. They work closely with workers to identify hazards and establish effective control measures. Central to this model is the preventive component, a proactive approach to maintain a healthy working environment and prevent occupational diseases. Employers have a crucial role as well. They must communicate clearly with employees about the procedures for reporting occupational diseases and encourage regular reporting of any occupational safety and health risks. Workers, often being the first to identify these risks, must report them to supervisors promptly. Such reporting helps prevent potential accidents and occupational diseases. This participatory approach, integrating the perspectives of employers and workers' organizations, is essential for the effectiveness of the occupational health system. This comprehensive tripartite approach ensures that occupational health is managed collaboratively, transparently, and effectively, ultimately promoting a safer and healthier workplace for all. To conclude, this inspection campaign has provided us with critical insight into the current landscape of occupational disease reporting in Brunei Darussalam. Too often, we convince ourselves that massive success requires massive actions. However, as we all know, big things often start from small beginnings. Even though this initiative is still in its early stages, it is clear that improving occupational disease reporting remains a complex and challenging task, as highlighted by the multifactorial issues, competency gaps, and system-level constraints faced by registered medical practitioners. Despite these challenges, the campaign has laid a solid foundation for greater awareness, stronger collaboration, and constructive feedback, all of which will guide our future improvements. Most importantly, we wish to emphasize that this is not a task we can accomplish alone. To truly strengthen our nation's approach to occupational health, we need the full and continued support of other divisions within SHENA as well as our key stakeholders. With Brunei's ratification of ILO Convention 187 and the upcoming ratification of Convention 155, the expectations on our national OSH system will only grow. It is crucial that we work together, break down silos, and bridge gaps to ensure that occupational disease reporting becomes an integrated and proactive part of our health and safety culture. Thank you for your attention and engagement throughout this webinar. Let us continue to collaborate and support one another in making Brunei a safer place to work and live, in line with SHENA's vision.